highly educated sessions that we are going to have as usual, and with very highly esteemed speakers. So I'll not waste any more time. I will hand over to Dr. Kudus Walal, who is the moderator of the session. Over to you, Dr. Kudus.
Thank you very much, Prof. And thank you for welcoming us all to this session of the 2024-2025 African Cancer Research and Control ECHO program. This session, today's session, which is that of March, is a very interesting one and one that promises to leave all the audience with important message to go on with. It focuses on strengthening cancer service delivery in Africa, leveraging community engagement, innovative access models, and coordinated solutions to overcome challenges. We all know how key and critical access to care is. And today, our panel of experts will be delving into the critical issues within Africa's setting and how we can ensure that everyone have access to care. Today's, as a reminder, some housekeeping rules. Please ensure that your mic are muted all through this session, except you need to speak. And if your bandwidth will allow, we encourage you to put on your video so that it allows for interactive session. The chat box is available for us to all introduce ourselves and ask questions and make comments. The administrative team and myself will be going through the chat to pick your questions. If necessary, you can put on the subtitle function, and we shall ensure that recordings are available on our YouTube. Dr. Kudus Lawas have been introduced. I'm a member of the steering committee, and I'll be the moderator for this session. The session is simple. We have a didactic section that will be presented by Dr. Sharon Kampambe, who we all know is a technical officer in WHO, and will be giving us some didactic on this topic. We have two case presentations. First from Ms. Eve Mai, forgive me if I pronounce that wrongly, who is from Humanity at Art International, Cameroon. I also have Gerard Paris from Choosing Wisely, who will also be giving us some case presentation. It promises to be an exciting session, and I implore you to take your paper and pen and take notes, ask questions, and ensure this section is interactive. Thank you very much. Without wasting our time, I'll go quickly to the first presentation so that I'll have enough time for interaction at the end of the day. I don't know, is Sharon ready?
Yes.
All right. Thank you very much. Thanks for giving us time within your limited time to share your expertise with us. It's always good listening to you.
All right. Okay. Thank you so much. And I need to make sure that I put a disclaimer. I am just recently, I just moved on in transition into another job from Afro. So basically this time I'll be presenting from the knowledge that I've gained from around. And of course, so that will be my perspective, giving it as an expert as well. So as you can see, until recently, a few weeks, I have been working with the WHO Afro for the last 4 years. And of course, I will be able to inform you once everything is finalized as to the next station or the next position that I will be holding. I will let you know. So I had been told that I should be make a presentation, which is just speak to it. But again, I do have, I think, a presentation that I had done in Nigeria, which I was hoping, because we're talking about community engagement, stakeholder engagement, which I had presented to the group there. And to a certain extent, I feel I could, if you could allow me, maybe that is something that can also work, that I can be able to give some perspective, of course, come and give a perspective of that. So if the share, I can be able to give you this presentation, please. It might not be what you are looking for. And I apologize, I'm in between jobs, so things are really all over the place. And let me give credit to the WHO as I presented this during that time. I think the most important thing that I wanted to discuss today is when we're talking about community engagement and how we can work in the cancer space, is really we need to, as community actors, as advocacy people, to be able to understand that a stakeholder is somebody who has interest or influence. So you, as a community person, has to understand perspective, and we need to care for the particular cancer advocacy. In making implementation policy program and determine what is the interest, the and they are as about improving, we need to have all. One of the things that I talked about it in that presentation and to this presentation, one of the key things in advocacy that we should be able to look at is manage our performance. Most of the times that community engagement actors are involved in is the inability to be able to say what it is they have done, to monitor what it is that they are working on, and to exploit the opportunities that exist. And then what you need to do to react and change course if something is happening. And it's also important for you to be able to attribute, this is what I've done, this is what I have done, and this is what the other stakeholders have done. So in this space, we need to make sure this is happening. We need to track and be able to measure what it is that we are doing. Measuring our long-term, measuring the tipping points, and what's to be able to say, for example, something like cancer incidence, to see that change takes a lot of time, as most of you are aware. So there are some tipping points that we should be able to sing about as advocates, as we engage the community. Has there been a change in policy, even though we haven't seen the disease going down? Have we heard a pronouncement that government has made? Has there been any budgetary commitments that have done? Is there any implementation of those commitments? So the long-term outcomes will have a little more other points that are coming. And when we, as community engagement and looking at what we are doing, we should be able to look at some of these things. So, tipping points, change in policy. If we have been fighting for tobacco or alcohol, if we have been fighting for those, and then we see that there's change in policy, and now we see that you are no longer allowed to smoke in closed spaces or in public, that is something that the people working in the community part should be able to do. Women have been allowed to start screening with HPV tests, something you can talk about. A change in legislation should cause you to be able to talk about those things. One thing when we are talking about community engagement and how we can improve that to be able to enhance cancer services is coalition building. Those are intermediate things. It's not the final product, but we need to learn that if we are going to improve cancer services, we need to invest in coalition building. That means that we need to look at items, the oral, the written of what is happening, and be able to have coverage of issues in the media, items that are framed in new ways within policy arguments. New items, if the minister is beginning to talk about cancer treatment, are we picking that so that you are beginning to build that coalition? And one other thing is shaping the policy agenda. Key decision makers change knowledge, attitudes, and behaviors so that we can see, are these things beginning to change as we are working? Influencing policymaker attitudes and behavior. Building a social movement. If we're going to work in isolation, it's very difficult for us to build a social movement. And that communities acquire new information, communities change their attitudes, communities change their behavior. Are we seeing these coming in? And we should be able, once we see these, we report them. That is also something that is very important. Some examples that I gave of advocacy: introduction of HPV vaccination in a country. What age is being involved? If the government says we've increased the age of the people who will be getting a dose, we have changed now to single dose. Are we using a campaign mode? Have we changed to school? Is the Ministry of Education involved? That is specifically when I'm talking about HPV vaccination. How have we engaged the key stakeholders into those? Availability of cancer services, which is cancer treatment services, which is a big challenge in our settings. What is the government's policy commitment? Do we know, as people who are part of the community changes, what the policy commitment is by government? Have we taken interest to see the policies that government has as far as cancer treatments is concerned? And if we find there's something lacking, that is something we start fighting for a policy commitment. What has been there for budget commitment? Did the government make a commitment? Have they lived up to that commitment? How can we move on to ensure that that commitment is done? If we look at prevention and management of obesity through the life course, there are different things, individual susceptibility that we want to be advocating for, the biology, the genetics, people should know about it, the regulation on harmful marketing of food and beverages to protect children, the physical and pricing policies to promote healthy diets. These are some of the examples of how we can be able to work and be able to shape our advocacy, our engagement. School food and nutrition policies, because at the end of the day, even though we're talking about cancer services, such advocacy at different levels will be able to come and shape that. And what I want to move on to now, I thought I could do a slide, and please make sure you alert me of my time, is really the WHO released, because I saw a bit of patient navigation, and I thought these are some of the issues that we should also be released a document in October last year for the breast cancer patient navigation. And breast cancer patient navigation is basically talking about a strategy which aims to be able to ensure that we help with individual and also system challenges that can occur. So when we look, and I'm going to take the breast, and then we look at it from the community engagement aspects that we're talking about. When we look at the 3 pillars for breast, we've got the pre-diagnosis, where we're talking about health promotion. That we have the 60-60-80, so that 60% of the women are going to present with early stage breast cancer. What that entails, when you look at that from a community engagement perspective, is that it means that then we are going to look at education of women. The women can only come early. The women can only reach the facility if the people in the community are able to give them education about breast cancer in this example, or cancer in general. So I have to have information. So it is partly the role of the community as we engage as community engagement that we're talking about, that health promotion is promoted. Do the women understand what the risks are? And this is particularly for breast cancer. How do we get these women to be able to recognize the symptoms they are having? And if they recognize the symptoms, they come into the facility, ensure that these symptoms, they have been checked. And if there's a suspicion, a clinical breast exam has been done by the facility to ensure that they move to the next stage, which is the next pillar of timely diagnosis. That the woman will be able to move through the system. And remember, I said individual and system related. So there are things that me as Sharon could be struggling with that community engagement should look at. And there are things that the system that I'm working on. I'll give an example, working in Zambia in the cervical cancer program. So there's a lot of siloed work that goes on as we talk about community engagement and the actors in community engagement. I was on the part of early detection and also working with the people who were doing HPV vaccination, and I have the people who are doing treatment. So what you find is that the people, we will go and do the health education. Women should come in for screening. We explain what visual inspection with acetic acid is, and they come in and we do the screening, and some of them will actually come in when it's actually a diagnosis you're making. So we see, oh, this looks like they actually already have cancer. You make a diagnosis of cancer. I explain, okay, madam, this is the situation. Unfortunately, the labs have confirmed, we've done the pathology that you do have cancer of the cervix. And you need to make sure you go and get treated. And I'm not the only one giving. Somebody else in another district is doing the same. Somebody else is doing it at provincial level. And we're telling these women to go and get treated. Key issues. So the woman now has to move on her own from being given this diagnosis, or maybe it's not even a diagnosis, is that this woman has been found with early lesions which cannot be treated at the facility, primary health care, and needs to go maybe to a district hospital. And first, she needs to understand, what is this? She'll go home, their husband, you say, what have you brought in the house? Why are they going to treat you? What is happening? There are already power dynamics that happens for that woman to move. So the next part is there are individuals, she's facing some challenges. She could be having economic challenges where now I've told her to go to the facility next. When she goes to that facility, oh, the doctor has gone for a workshop. So we cannot do your leap, we can't do the procedure which we were supposed to do. You have to come back 2 weeks. She's got opportunity costs. She's got children to look after. She's got a farm that she's working on. She has to feed her kids. She has to do her usual work that she does. And she has just gone all the way, spent a whole day, even 2, slept somewhere, just to be told that the doctor is not available. He's on break. He's already in theater. So there's already a break in linkage. We should have known when we were referring if that doctor is going to be around. And this is what patient navigation is coming to do. This is what people who are working in the community should be able to do. So she goes, the next stage is, oh, you actually have cancer. So I have given someone a diagnosis of cancer and encouraged them to go and get treated. And the team in the treatment have no idea how many women in my program where I'm doing this, giving these results of the diagnosis, how many have we done around the country? They have no idea. There's no data linkage. So if women go back home and they never go to the treatment center, I don't know if they reached, I don't know if they went. I just told them, you go, there's no one to take them there. And on top of that, the cancer team has no idea. They have no, who are they expecting? How many are they expecting? When are they expecting them? So there's a break in data, there's a break in communication, there's a break in coordination. And we will lose women. And this is a woman you have found in the village who has no idea our treatments are centralized. So she has no idea how to move from this primary healthcare facility where you've told us suspected cancer, or this district hospital where actual diagnosis has been given, to back there. The other side is that this woman is getting treated, she gets a break, go home, come back after this for review and everything. The nurse who actually suspected the cancer has no idea when the woman comes back, and so cannot encourage this woman to continue with this treatment or to be followed up if anything is going on. So within the system, there's a break. Even if the machines are not working, this woman will move all the way 400 kilometers to a place where she finds, oh, the machine broke down 2 days ago. While we should have said, machines are not working, we wait for you to come back later. So the issue then becomes, we have these points, we are siloed as cancer teams that are working at country level in the way we are treating these women. That is where the navigation, the women and men and children, the navigation is for everybody. Probably does a lot of with women. So for me, as we look at navigation, as we look at individual factors, as we look at systems, those are things we should be able to look at and be able to see. If we're looking at timely diagnosis, does the woman know where she can get this diagnosis done? Is it available? Does she have to pay for it? When it comes to treatment, they just go and then maybe the oncologist will explain something, but the woman will probably not know much. So please let me know if I'm running out of time so that I do not.
Yeah.
I do.
Yeah. Just have a minute more. Thank
All
you.
right, thank you. I thought I was. So if we come to, we have got timely diagnosis, are the services available? What are these results for? Why do I need to do them? If I'm getting treated, where am I going to get treated? How long is it going to be? What am I going to be doing there? So partly of that navigation is that a woman, even for treatment, should make an informed decision. Two, if there are any barriers, economic, social, psychological, navigation will help with all this. At the end of it all, with what I've presented, is that we need to also measure it. It shouldn't be because we're working in the community, then it's a free fall. We should be able to measure our work by pronouncements, by change in policy, by seeing commitment in budgets, and be able to go back like, this is where we came from, because sometimes it can be discouraging when you're working in the community. You feel like you're not doing anything because you're expecting until they say, oh, we have treated 100 women. There are other things and they are all fine now. They were treated 4 years ago. That's a long time for you to be able to stand. So the roles and competencies of those people who are going to navigate these cancer patients through the system become key. They should be educated. They should understand the pathway. They should understand what is needed at every point. Cancer navigation has been seen to work, especially in low socioeconomic status, to help the women make decisions, to help cancer patients make decisions through the system, and how to be able to ensure that the bottlenecks are decided. This is from a patient perspective, how do we go about it? This is a system perspective, how do we go about it? So thank you very much for having me and for letting me share some of the things that I had to share, and the importance of stakeholder, understand their interest, understand their power, and then we will have a better community engagement. And if I've gone off topic and everywhere, please do forgive me. It's so much going on, but thank you so much for having me.
Fortunately, you've not gone off topic. We really appreciate what you presented to us. If you're just joining us, you just listen to Dr. Sharon Kapambe. I'm sure she's known to many, but just to highlight a few of who she is. She's actually the immediate past president of Medical Women Association of Zambia, an association of over 1,000 female medical doctors. She has done a lot in terms of cancer prevention in East and South African region. She is known globally for her role in cancer prevention. Thank you very much for this presentation. We hope you'll be around to take questions at the end of the session. Thank you very much. So very quickly, to ensure that I have time for conversation at the end of the day, I'll go to the first case presentation, which will be taken by Tata Maya Evelyn. Tata Maya Evelyn is the founder and executive director of Humanity at Heart International Association, a non-profit organization that focuses on breast and cervical cancer health and prevention program. She is into patient navigation and policy-based advocacy in Cameroon. She's a steering committee member of African Cancer Alliance, Health Alliance, and a steering committee member of the African ECHO 2024. She's a UICC fellow, and she has built a strong profile and reputation as a cancer champion and leader in civil society engagement. There are lots to Evelyn, which I will be telling you as the event goes on. But I need to also mention that she's one of the 3 members of Cameroon team in the International Cancer Control Partnership. So you have an expert giving us a case presentation today. Join me in welcoming Evelyn Maya as she takes the floor to speak to us. Maya, you have for the next 15 minutes. Thank you.
Thank you so much, Dr. Pedus. I think listening to Dr. Sharon, I just have to run down through the slides because she's captured most of the things. Will the Secretariat be able to share my slides, or I share from my side?
I think you can share from your side so that we don't. Okay, the Secretariat will share. Thank you. Thank you, Charles.
Okay, thank you, Charles. So after listening to Dr. Sharon, I'll just run through this. And thank you for that great introduction, Dr. Pedus. I am Evelyn Tata Maya. So I'll be talking basically on what Humanity at Heart International has been doing in relation to strengthening breast and cervical cancer service delivery in Cameroon through our community-driven and people-centered care, which is patient navigation. Next slide. Before I do that, I would like the participant to know briefly what we do. We are actually a registered NGO in Cameroon which focus on cancer prevention and policy advocacy with a mission to raise public awareness on breast and cervical cancer prevention and facilitate access to timely treatment regardless of where the women are or also economic status. And we envisage a society where every woman has equal and equitable access to healthcare information, screenings, and when needed, timely treatment. So to facilitate all this, we have grouped our work into 5 work streams. The first one being community outreach, and then patient navigation, which I will lay more emphasis on, and then advocacy, wellness counseling, and cancer survivors empowerment. And we do not just work in silos, we work in collaboration with our Ministry of Health, and we have an organigram that we follow. We pass through the regional delegation office of partnership, then we have authorization that we can work through the regions at all district health areas, and then we report to the National Committee for the Fight Against Cancer, who in turn will report to the Ministry of Health. Next slide. So Cameroon actually has a population of over 27 million. And the burden you have heard Dr. Sharon mention is really high incidence, high mortality with breast cancer ranking first with over 4,200 new cases, and half of this number dying from it, and with cervical cancer ranging to over 2,525 new cases, and also half of this number dying. And as some of the challenges, we have access to screening and treatment severely limited, particularly in rural communities where we are more focused on as Humanity at Heart. And we have women presenting late due to and giving poor outcomes. And the stigma and misinformation surrounding cancer prevent many women from seeking care on time. And actually, we have follow-up difficulties due to resource constraint and logistical challenges as well. So we have women of reproductive age and those who are living with HIV facing quite enormous challenges in regards to these cancers. Next slide. Next slide. So we realize that there is an urgent need for effective community-driven and people-centered care. And the reason to this is because we need to reduce the stigma and misinformation associated with cancer, and we need to improve early detection and diagnosis of breast and cervical cancer and facilitate access to quality care, including treatment follow-up. And we equally need to provide support for these patients and their families and addressing financial barriers, not just financial barriers, but other barriers, as we've heard Dr. Sharon mention, and improve survival rates and quality of life for individuals diagnosed with breast and cervical cancer. Next slide. So to achieve all these urgent needs that I've listed, Humanity at Heart has put together, we have put together a vision to be able to be accountable with what we are doing in terms of patient navigation, being a community-based service delivery intervention that is designed to promote access to breast and cervical cancer screening, early diagnosis, and when needed, timely treatment by eliminating barriers. So we have put a vision of a future where communities have access to breast and cervical health information, resources, and confidence to navigate the health system effectively, regardless of their backgrounds. And our target population for this navigation program, we are targeting women of reproductive age and women living with HIV who have had suspicious findings after their breast and cervical cancer screenings, and with the resolution of this finding by further diagnosis and treatment. We have cited 2 community areas that we are more focused on. We focus deeply in rural and underserved community and a part of peri-urban areas of Cameroon. And we do not work on our own. We work in collaboration with health facilities that are offering screenings, health facilities that are working treatment and diagnosis services, like the Cameroon Baptist Convention Health Services. We've worked for over the years with the Women's Health Program across the regions wherever the services are. And then we work with the General Hospital that offer radiation therapy, as well as the Cameroon Oncology Center. Next slide. So in 2020-2022, we were able to launch a 3-year Operation 1000 Women campaign to address some of these challenges to ensure that women receive timely and appropriate care. And the main goal for this campaign was to link at least 1,000 women of reproductive age and women living with HIV from the communities every quarter of the year to vital cervical and breast cancer screenings and navigate those who are having suspicious findings to further diagnosis and treatment, and lay emphasis on comprehensive follow-up and empowering survivors and reintegrating them back to the communities to take control of their health and their futures. So we've had presentations over the media to talk about the Operation 1000 Women. We have had community outreaches. We have had workshops to talk about that, to be able to have women educated and have access to information, to be able to access screenings and treatment when needed. Next slide. So some of the core strategies, I've just mentioned them. I will just do a repeat on that. We have had to work with local chief in terms of community engagement. Each community that we visit, we go to the local chief, we work with the religious leaders, women's groups to be able to build trust and raise awareness. One thing we need to understand is that in the rural settings, most people do not really trust the health system, maybe of its complexity. And so we work to build trust with these local chiefs, religious leaders, whom the community in some sort trust them when they speak. And then we have also conducted series of educational workshops in the local languages, because language sometimes is a barrier. And what we do is when we cite a community that we want to work with, we take community health workers that are able to speak in the language that the communities will understand. And most often we have used our broken English, we call pidgin, to be able to break through the barrier of language. And we have had series of workshops too with the journalists to be able to tailor key messages as they are, as accurate, so that the misinformation and misconception about cancer, breast cancer and cervical cancer are demystified. And the access model, we've made sure that quarterly screening campaigns in community locations that we've cited, we collaborate with health facilities that are using clinical-based navigation to streamline referrals and treatment, so that these women are not lost to follow up once they access screenings and they have positive diagnoses that need timely treatment. Next slide. So to achieve all that I have mentioned, we have interventions and how our patients flow. We have patients that either they self-present to us at the center, or those that we have identified during our community outreach programs. But all in all, whether you're identified at the center or you're identified during the community outreach program, we have key services that we will offer. The first step is to do needs assessment and see what relative information you need or what service you would want to adhere to. And then we'll provide information and we identify the barrier that the woman is facing. If the woman needs appointment, maybe for screenings or for treatment, we make sure we do that and we ensure that we coordinate care. Having a cancer diagnosis is very challenging and overwhelming. So we make sure that we counsel the women, and should they come back as survivors, we integrate them back into the communities. And we also carry out advocacy, precisely policy-based advocacy. We want to do more of evidence advocacy. Once we do all these, the patients that have normal results, that are not diagnosed with anything, we give them further appointment as per what the technician or the physician would say at the clinical navigation service. And then this woman is rescheduled for another appointment, probably in 3 or 5 years, depending on their HIV status. And those that have been diagnosed with abnormal results, we then work in collaboration with the facilities I had earlier mentioned to either go for their chemotherapy, radiation therapy, and we do need assessment to see which of the facilities they are able to adhere to, depending on their financial status and the distance to the health facility. Next slide. So we believe and we know, and all of us will agree when listening to Dr. Sharon, patient navigation is a valuable approach and a game changer to linking these communities to healthcare. One is we bring health services directly to the communities to make them more accessible to individuals who may have transportation or other barriers. And we often work with members of the same communities who understand local customs, belief, and language preferences to improve community communication and trust. and we are able to understand patients' lives, including the social, economic, environmental factors that can impact their health. And this allows us to provide more comprehensive care. And so by working within the community, we build relationships with other local organizations and resources that support networks that can benefit both patients and community as a whole. Next slide. So we've put some coordinated solutions in place, ensuring that there's continuity of care in Cameroon. So we've had dedicated patient navigators and some volunteers who provide personalized support at every step, be it at screenings, be it at treatment, be it at reintegration back into the community, to make sure that patients are not lost to follow up. And we make strict follow-up protocols by including phone calls, home visits, to minimize loss to follow-up. And we equally offer psychosocial support and counseling to address emotional and social impact of cancer on the women we serve. And we ensure that we track data at our level to be able to monitor these patients' progress and program effectiveness. Next slide. So the impact and results we've seen so far, we've had increased healthcare access, especially when you accompany these women and they feel safe with you. And we've had increased screening rates, early diagnosis, and adherence to treatment plans, and reduced healthcare costs. And we've increased trust in the health system, like I've mentioned. When you have women who know that you're going to accompany them to healthcare facilities, they are more at ease, knowing that they have someone that is guiding them through all the steps of the way. And then we have improved patient health outcomes and well-being of individuals in the community. Next slide. So these are some milestones we've achieved from the 3-year Operation 1000 Women program. We reach out to over 17,000 women, both over social media, TV, media outreach programs, and workshops. And together with CBCHS, we were able to vaccinate young girls of age 19 to 14 in rural communities in the Northwest region. And we've had over 1,000 women, eligible women, screened, and 97 were referred to health facilities for recommended treatment. Yeah. So to build this patient navigation program requires getting buy-in from community stakeholders and potential funders. That has been challenging. When you navigate these patients, they would want everything to be free. I listened to the amazing presentation from Dr. Sharon. We see a woman who lives from a long distance to go to a health facility just to be told the doctor has gone for a workshop. She's worried about what to eat, where to stay, how to transport herself back. And that needs a lot of buy-in and support for these navigation programs to be able to reach the people who need navigation the most with equity and inclusion, and increase uptake of navigation services to maximize program impact. And we work in collaboration with other health facilities, and that's what we encourage. So we are planning to relaunch again the Operation 1000 Women at a larger scale for the next 3 years. Next slide.
Yeah. Okay.
So I would just want to quote Dr. Harold Freeman, the founding father of patient navigation. No person with cancer should have to spend more time fighting their way through the cancer system than fighting the disease itself. So we ensure to walk a mile in our women's shoes to be able to know how it feels. Thank you so much.
Thank you, Maya, for that beautiful presentation. And I hope our listener and audience are able to tie together Sharon's presentation with Maya's presentation. There are key things Sharon made reference to that Maya has been able to emphasize in her presentation, and that's the beauty of our program. Now, please try to introduce yourself in the chat box and put your name, your affiliation, to ensure that you're properly recognized in the meeting. Thank you. So very quickly, I'll be moving to the next case presentation so that we can have enough time for the discussion session. The next presenter will be Gerard Paris from Walter Sisulu University, Eastern Cape, South Africa. Gerard Paris is well known. He has been an oncologist for a very long time, since 1998, and I've worked in several institutions and universities throughout South Africa. He's a clinician, a researcher, a lecturer, and has some venture into private sector. He's very interesting. Sorry, if you're not speaking, please ensure you mute yourself. Thank you. He's on the steering committee of IAEA-based Afronet Group and the Common Sense Oncology Movement, a group designed to take the agenda back from drug companies and return it to clinicians, ensuring that easy access to care is available to all that needs care. So it's our pleasure to have him speak to us on this important topic, and I'm sure we are going to enjoy the conversation, which no doubt is going to enrich our knowledge. Over to you, Gerard Paris, and thank you for having time for us. You are muted, please.
Yeah, I just want to share my screen, and then
please go ahead.
And then I can start from the beginning here. All right.
Yeah,
you should be able to see my title slide now. Choosing Wisely Africa. Okay, thank you for that. Thank you for that introduction. I might be in some ways a rebel with the cause for, along with increasing numbers of colleagues, as to the good decisions that we need to make. So, am I stating the obvious here? Any intervention must make the patient live longer and or feel better, without exception, no matter what the intervention is. It must make the patient in front of you live longer, feel better, or both. This sounds so obvious, and yet the fraternity as a whole, not only oncology, but other branches of medicine and indeed in other areas, has obfuscated in some ways itself away from this key role into various irrelevancies. The problem being, excuse me, as drug companies took over, as I'll show you now, the randomized controlled trials, the endpoints and methods were changed to suit them, and principally progression-free survival and other surrogates, and over-selected entry criteria. Now let's look at this. Surrogates are a measurable parameter which is spun to conclude that its observation has implications in other areas, and sometimes quite convincingly spun. Progression-free survival is the kingpin, but there are others. So, for example, to conclude that if a new treatment causes a smaller asymptomatic nodule in the lung to take a few weeks longer to become a bigger asymptomatic in the lung, a nodule in the lung, that this treatment will improve the patient's quality of life or life expectancy. And that is a huge leap of faith. Similarly, what do you read into a treatment that delays the increase of a PSA level by a few weeks? What do we read into that, especially when factoring the toxicities and the costs of the recommended treatment? With regard to population criteria, this has gone completely bizarre. Often trial populations are actually healthier than the general population. Common diseases like diabetes, hypertension are cited as exclusion criteria. And yet after the trial's done, the treatment is marketed as standard of care for everyone. In our case in sub-Saharan Africa, progression-free survival and comorbidities are especially relevant. And they're often in the report of the trial just fobbed off in a small table in some corner somewhere. Entry criteria, PS0-1. In other words, you're giving palliative treatment to a patient with no symptoms and no comorbidities. The implication, PS0-1, the implication that a performance of 2 and above, which the vast majority of cancer patients have, are excluded from this, what was that? Are excluded from the trial, and yet the results of the trial could actually be applied to them. We must be extremely careful when results are marketed in this way. And as I'll talk to you later, this is not just a problem in sub-Saharan Africa. In fact, it has emerged, surprisingly, that the cost and efficacy of cancer drugs is not unrelated, it's actually inversely related. Now, we might be thinking that more expensive drugs, okay, they are more expensive, but they do more. But in fact, it's increasingly, in a large number of cases, being shown that they're doing less, which I'll show you in this graph. So here we see the first point that I made, the evolution of randomized clinical trials in the area of precision oncology. As the industry funding took over the trials, so overall survival as an endpoint came down, and progression-free survival became the primary endpoint of the trial, as it was marketable and could be used to sell a product, even though it might not have any implications for overall survival and definitely not for quality of life. Now, this is quite understandable. I think any drug company would have been forced to do this in order to market their product. And significantly, there's been no association between the magnitude and benefit of drug price. Now, this is situational. It might be more a feature of developed countries, where enormously expensive, ineffective drugs are given in the last 6 months of life for whatever reason. So, look at this. What do we do the way forward? Are we going to advocate more patient-centered RCTs in the future? Can we not agree to do an RCT unless it's something that really is going to benefit the patient? Secondly, better commentary on phase 2 and phase 3 trials, and this risks complications with interested parties. But no matter what people might say, the only purpose and the only outcome of a phase 2 trial is to assess whether a phase 3 trial should be attempted or not. There is no other information it gives. Similarly with a phase 3 trial, if they've shown that a certain treatment delays the progression of a MET in terms of its increase in size or appearance of a new one, they have then also to answer, does this observation have implications for the patient's quality of life or life expectancy? Otherwise, if a treatment fails to improve a patient's quality of life or life expectancy, it has failed completely. This encourages the movement of clinicians to take back the principle of the application of data. It's challenging, giving some entrenched practices and lobby groups, but we have to say, what will this do for my patient? The patient sitting in front of me, is it going to increase his life expectancy? Is he going to feel better, or a combination of the two? However, very importantly, nothing should be taken at face value, and anybody involved in this will acknowledge this. Despite what we're saying here, it is possible that a new treatment that will eradicate melanoma might first appear as a drug that delays the progression of an asymptomatic nodule. I personally doubt this. I'll tell you why. Excuse me. Is because all curative treatment that has emerged historically has been so obvious from day one that no observations like that have ever been necessary. So the role of cisplatin in curing germ cell tumor wasn't discovered because it initially showed that it delayed the progression of metastasis. It was shown to cure right from the outset. However, critically, cure is not the only property that makes an intervention vital. If that were the case, you would be asking yourself, well, why are we giving insulin for diabetes? Insulin doesn't cure diabetes. You don't get diabetes, get a shot of insulin, and then you don't have diabetes anymore. It's got but it has a critical managerial role. So the fact that an intervention does not cure a disease, cure a cancer, does not mean it is not potentially of great value and essential. And in fact, the vast majority of interventions for all diseases do not cure them, they manage them. So the key is for us in our situations to take back the agenda of management and determine what interventions benefit our patients in terms of making them feel better or living longer, and not to be duped into this by false statistics. So Africa, the good and the indifferent. There are some key points to take from this. The lack of certain subtypes of drugs, particularly biologicals, has less of an effect on our outcomes than we might expect. As precious few of these patients would have been eligible for the trials that produced these results, and even those with good outcomes, and those are few. Whereas in biologicals that are effective, like for GISTs of the gut, those treatments are generally more available. Discussing the desiderata or assessing the desiderata of better quality of life and life expectancy is situational. Investigations must be done locally and holistically. The principles are the same everywhere, but the application is very situation specific, and we must not be afraid to work with that. If we fail to work with that, even though sometimes it's unpalatable, we will not be sufficiently goal-directed. And I think I saw a recognition of this in some of the previous talks. They were dealing with problems and challenges that were specific to their surroundings, rather than pretending those didn't exist and shooting for the moon when it comes to the latest practices marketed as standard of care. But the point I'm making, not only that, but that standard of care is often marketed along suspicious lines. In that way, we are often protected from an undesirable process in terms of marketing with surrogates and over-selected populations that has developed over time in many areas. And we could actually illustrate the folly of this thinking to the world around us. So I would advocate, and this can be done in conjunction with the various interest groups, ECHO being one of them, a body to examine the marketing of products and processes and assess their real value in various contexts. So it has to include processes, not just products. That includes nutrition, transport, access, and it has to be contextualized. You have to individualize to the situation that you're working in. And this can work with several concerned groups overseas, of which there are several. I've been most involved in the common sense oncology movement. I'm told reliably there's a similar movement among anesthetists to take back the agenda for clinical decision making to the clinicians. Secondly, to investigate guidelines in consultation with facilities and locations as to what action would be effective for them. Initiate research along those lines, including critically qualitative research. The reason why we don't know patients' problems because we don't ask them. And counterintuitive thinking in these lines might be profound. We might find that a certain object, a certain procedure, a certain initiative is better not taken or not taken now. The attempt to be better goal directed as a center for overseas-based investigations. That is to say that if an overseas company wants to come and do investigations within the African context, we tell them that they must do what they should do in any context, not just the African one. And that is investigate procedures, drugs, interventions that will actually be beneficial to patients in terms of making them live longer and feel better, not to investigate the effect of something that has on a blood test or a little nodule in the lung that might not even be carcinoma. So with that said, there are some surprising results, and in many of them, in a way, are rather encouraging. Firstly, our patients, those and colleagues, I'm talking about realistically the patients that we are dealing with here, are jeopardized in many ways far less than the pundits would like us to believe by using older treatments. As I pointed out, the newer, more expensive treatments are often shown to be less effective. They might be more specific. They might have a different side effect profile, but they're actually less effective. And secondly, the population involved that's on which this work has been done sometimes is way different from what we are dealing with. I've been involved in lung cancer quite a lot, and the EGFR group of lung cancer in non-smoking Asian women particularly is just about as far removed from what we deal with every day as it possibly could be. Then we can afford to be far more focused on individual problem solving. Whilst this could appear unscientific and even prejudicial, it is a reality. Dietitians do not solve a famine, food does. So we need to work together with colleagues in other areas to make sure that our intervention makes a patient live longer or feel better. Very simple. And that does involve working in collaboration with other service providers, other areas, rather than just pure oncology. This, to my mind, is a flaw in the developing NHI concept in South Africa. In many discussion groups, I've said to them, what is the actual health you're talking about? Do you want to provide a new expensive drug to somebody who needs clothing and water and transport? What health are you actually wanting to provide? And I've never really got an answer. Go back to then saying an intervention must make a patient live longer or feel better. And along those premises, there is huge scope for variation, for us to work with other interest groups, with other activities, with other organizations, in a multifaceted approach. But denialism in all environments is a huge risk. Denialism in less developed environments, where we ignore the fact that more basic needs need to be addressed, and denialism in wealthy environments where they pretend that a surrogate marker is going to increase the time a blood test takes to increase by 6 weeks will have major implications for the patient with the condition. So denialism is a problem. So finally, I say choosing wisely Africa. That should not have been my topic. It should have been choosing wisely, not choosing wisely Africa, because in every area, no matter where you are, this issue of what is properly choosing wisely is emerging. Increasingly, it's emerging that in wealthy areas, the true goals have been supplanted by massively expensive interventions that offer little benefit. And therefore, there is little I have stated here that is not just an African issue, although the specifics of how you achieve these goals may differ from place to place. Thank you, ladies and gentlemen.
Thank you very much, Gerard Paris. Is not choosing wisely Africa, but choosing wisely. Yeah, a lot of times we agonize about how we are not having access to current and new treatment interventions. But Gerard has asked us to take a moment backward and rethink these thoughts on the newer drug does not necessarily mean better drug. And we should start looking at how drugs and intervention make life longer and better, and not necessarily getting new intervention. Thank you very much for that elucidating intervention and discussion. So we are now at the time of discussion and question. So if you have questions, you can use the chat box, and if you think you need to speak, you can use the hand raise option of Zoom. I would identify you. But just to summarize and put some of the things that have been said into perspective, I would be trying to bring together the key things I've jotted down. Sharon talked about managing performance. the ability to communicate what you are doing is important. It's not just about going to the community to carry out interventions. You need to be able to communicate what you are doing, what you need to do, and attribute what you've done and measure your outcome as well as your impact. This is key in order to assess the progress you are making, where you are, where you want to be. You need to make measurements and you need to interact. We shouldn't work in silo. This is one issue that needs to be addressed, especially in this part of the world. We need to start working together. We need to have handshakes between programs to ensure that we work hand in hand to achieve our goal and not in silo. This Sharon spoke to and emphasized. And she gave an example of how production of HPV vaccine, how availability of cancer treatment, examples of how you can advocate, you can work together in advocacy. And Maya also spoke about what they're doing at Humanity at Arts, how they are leveraging on community-based navigation program to ensure care is gotten to people who need care at any particular time. She spoke about the challenges of such navigation and what they do to ensure the navigation process works well. One key thing that I picked from her presentation is the importance of language, how you should be able to speak in the language people understand in order to be able to navigate them well and navigate them appropriately. And she spoke about the fact that no cancer patient should spend time fighting the system rather than fighting the diseases they have. We must ensure that across the journey of care, patients are supported through that journey from diagnosis to treatment to survivorship. Patients should not be left alone to care for themselves. And no doubt Gerard sum it up with is saying that any intervention must make the patient life longer and better, or both, without any exception, and not just in Africa, but globally. So we should start rethinking how we make choice of treatment, how we ensure patients get access to care. These are things we need to, start taking critical look into. So without wasting time, I will go to the chat box to see if there are questions. If there are none, may take comments and discussion from the participants, then we call it a day. Thanks for being with us this far. Charles, please, is there any question on the chat box I'm missing? I don't think I've seen anyone. Okay. So I would leave the mic open for everyone who wants to make comments or remarks about what you've seen, about what you want to make comment about the conversation we had so far, your own view of how we can strengthen cancer care access in Africa. I'm looking out for answers. I've not seen anyone yet. Okay. Oh, sorry. Nakaganda, forgive me if I pronounce your name wrongly. Please, you have the mic. You can unmute.
Yeah, thank you so much. Great presentations, actually. And I joined a bit late, apologies, but I was able to listen to Gerard's presentation about the clinical trials. I'm from Uganda Cancer Institute, and I head the clinical trials division. From my experience, Gerard is true, and that when it comes to commercial studies and clinical trials, it's really a bit challenging. But I think we need, Gerard, in your presentation, your views, I need to hear your views about empowering our clinicians with the knowledge of evidence-based practice, so that at individual level, they can easily and quickly assess what counts as evidence. And as you may all know, it does not only depend on research that has been published, it depends so much also on the clinician's experience, but as well as the patient's circumstances and experience. Research can tell you what works. A clinician's experience and expertise can tell what works, as well as your patient can tell you what works for them. And all these of recent are valid sources of evidence. The challenge clinicians have is quickly learning how to appraise this research. because we rarely have time to practice it. But from my experience, you can quickly use 15 minutes or 10 minutes, Gerard, to see valid research or methodology or what. But we really need to make sure that as Africans, we get used to making sure that you only first look at the question, then go to the methods, and you can quickly, because you use checklists. But as you go on, time comes when you don't even need a checklist to assess the methodology and whether you should take on the research evidence or not. But even if it is good, your experience, for example, in Uganda and Kampala, may have already told you by documenting the outcome of everyone you treat. We don't document in Africa the outcomes of our patients we treat with certain interventions. And of course, taking time to listen to the patient of what has worked for them or not, and what they can afford or not afford, and what they believe in or not. So thank you, Gerard. I want your comment on this. Other than keeping on rubbishing, they will not stop marketing anyway. They are there to really market. We need to empower the users of the knowledge. Thank you.
Yeah, I mean, I agree with so much you've said there. I mean, when you talk of asking the patients, that is so much about that is neglected. I mean, I've seen the most ridiculous things in my career. There was one study assessing an effect on prostate cancer where they asked patients to evaluate their stream and their this and their that in a table, and that table was presented in was spun into a quantitative study to create a p-value, excuse the pun, and that research would have done far better if people had sat down and with the patients on the treatment and asked them if they felt better on it. Why didn't they do that? Well, maybe they were scared of what might be said, but also qualitative research is always contextualized. It cannot be spun into a generalized conclusion. So you might conclude this treatment has this effect on patients being treated at this clinic in Kampala. You can't spin that data into what the treatment's going to do for patients in Luanda. You know, for that you have to play with statistics to create a value. And that is another reason why patients are never being asked themselves to obtain results from those studies. When it comes to assessing the results, you go back to the slide that I said. Firstly, if it's a phase 2 trial, tell them right at the beginning, the only purpose of a phase 2 trial is to assess if a phase 3 trial is justified or not. If they draw any other conclusions from that, they're spinning it. Secondly, a phase 3 trial often does present statistically significant results, like the 6-week delay in the progression of a little nodule in the lung was highly statistically significant. Okay, it may be. Strangely enough, often that 6-week delay is just a function of the interval of the scans in the trial. So if the trialists scan the patient every 6 weeks, they'll end up producing a 6-week delay. They have to proceed beyond that and conclude what implications this observation will have for the patient. Is it going to improve his life expectancy or quality of life? And they have to factor in things like the toxicities in making that assessment, particularly if the treatment is palliative. And so the clinicians need to demand that extra evidence beyond presenting this treatment delays the onset of a second nodule in a HER2 positive second line metastatic breast cancer. Okay, what are the implications of that? Is that patient going to do better in terms of feeling better and or living longer? And the only way to assess if they feel better is actually to ask them, and that is not happening. That is not happening. And it's not going to happen unless the clinicians demand it. The patients can't possibly have the insight into making that call. The clinicians are going to have to ask for it. And I'm pleased to say that there is a growing swell of clinicians that are realizing this and saying let's tackle these drug companies. They've done an incredible amount of good. I mean, but you know they need, but this flaw needs to be addressed. Okay, thank you. I think you're muted. Salome
Thank you.
Meyer, yes, I know.
Yeah, I was thanking you, Gerald, for that intervention. I was emphasizing that it's high time we start looking at patient-reported outcome in cancer research and not just p-value of the next nodule coming up. These are things we need to start looking into in cancer research, and clinicians should start interrogating the evidence with which they are managing their patients. Don't just use a significant p-value to just take a decision in patient management. Thank you very much for that. Salome has her hand up for a while. Please, over to you.
Thank you, Kudus and Gerald and Sharon and Eve for your excellent presentations. I think I need to stay true to who I am in terms of being a cancer activist, never mind an advocate, to actually say that I think we need to, in Africa, as we are gathered here to talk about Africa, that we have to start talking about equitable cancer access. What does that mean, in fact, for all in Africa? What does equity mean from a perspective in Cameroon versus a perspective in Namibia versus a perspective in South Africa? Is that even achievable? And what is it that we are going to do to achieve actually that? But what we also need to do, and I'm glad that Sharon is still on the call, is that WHO has actually initiated extensive work on the lived experience. And especially last year, there was extensive work done with regards to the lived experience. So we need to start working on how are we going to make sure that the lived experience is in fact represented in every step of the cancer continuum of care, and that it's not just a matter of let the pharma look good when you involve the patient. It must be real actual involvement of the person with the lived experience. And I think that is in fact the challenge that we have as advocates, activists in the space of to say to each other, how are we going to shape that conversation where we will be working in collaboration with each other to achieve that? And that, yes, the silo approach in terms of us, that we actually embrace collaboration and that we work together across the line. That's my contribution. And I think that's a challenge that we have in Africa. Thank you.
The only comment I would say, I don't think it's just a challenge in Africa.
Thank you very much for that comment. The patient needs to be on the table. They need to have their voices heard. Their lived experience should contribute in planning and designing treatment options. Thank you very much for that. Sharon, you have the floor, please. Sharon, you're muted. If you're speaking, you have the floor, you have the mic. Oh. Please, can you hear me? Sharon, can you hear me? Okay, I guess she's having issues with her audio. Can I be heard, please? Gerard, can you hear me, please?
Yes, we can hear you, but I think Sharon is muted.
I think she's muted and she cannot unmute. Okay. So do you have any question on the chat box or any comments? There are no comments or questions. I'll hand over back to the chair. So Okay, Gerard has a comment. Okay, go ahead, please.
Yes, I just want to tell you from a personal perspective, some of these advocacies that I was involved in got me into quite a lot of trouble, not with drug companies, but with colleagues. Colleagues who were partly maybe affected by the drug companies or influenced or being rewarded by them, but also others who actually lacked the insight to conclude what I was advocating, and told me that no, what I was saying was wrong. People have been executed or sent to Siberia or whatever for their conviction, so this is nothing new. But it's interesting where I ran into contentions. It wasn't with the drug companies, it was with colleagues.
Thank you. Yeah, those are challenges that when you advocate, you probably come up. So I don't know if Sharon can speak in the next 1 or 2 minutes. Oh, Sharon is back.
Just
You're
1
welcome.
minute, yeah. I just wanted to say one of the other things, even as we are talking treatment to a large extent, what you see also in countries which brings a bit of conflict is when there are no agreed treatment guidelines for that country. So you find that this oncologist is doing this, the surgeon, and also the MDTs are not even there to be able to sit and discuss as colleagues. So we should, as advocates, you should make sure that just whether it's treatment guidelines, screening guidelines, there is a standard that you're following as a country, as opposed to each individual doing what they feel they should do. At the end of the day, it doesn't benefit the patient to have different people doing different things. Yes, it's different if it's a clinical trial like, they work on at Uganda Cancer Institute, but are they laid down guidelines for treatment? Are they laid down guidelines for screening? How do we treat? So you find there is prostate cancer, this going on, especially with these months of awareness, different things, and some of them could actually not be to the benefit of the patient, but we do them. And maybe that's where Gerald is saying it's also a lack of insight. Sometimes it's a lack of us reading enough and following up what has been done where and how best it suits to our environment. Thank you.
Thank you very much for that comment. Definitely, we need to ensure that we have using guidelines to ensure handshake between our data and what we are doing. We can make comparison when we use guidelines, and thank you for that. So I would hand over to Phoebe, who is the African Echo Hub coordinator, to give a 2 or 3 minutes announcement, and we'll call it a day. Thanks very much for being a beautiful and great audience. I'm sure you had a nice time with us today. Phoebe, over to you.
Okay, thank you very much, Akadas. Mine is very briefly, Kudus, thank you, good job. Mine is very brief, then I will invite the steering committee chairperson, Professor Nkozo, to close for us. Just to thank you for availing yourself. I have shared the link for the Africa Cancer Echo WhatsApp group. Please join us for updates and other sessions that are upcoming. For today's session, we are going to provide a certificate of attendance. So we will provide a certificate of attendance for this training session today, sorry. So thank you very much one more time to our wonderful presenters for your sacrifice and all the time. I think Dr. Sarah or someone had to navigate through the airport, and Pari was here severally before the planning sessions, and of course, Dr. also Maya, very informative. So thank you once more. Over to you, Professor Nkozo. Close for us.
Thank you, Phoebe. I think really what remains is for me to thank everybody for attending this very vibrant session. Strengthening of cancer service delivery in Africa is a huge and very interesting topic, and we thank our speakers for ably navigating through that and giving us a lot of insights. yes, it is not just an African issue, but as Africans, we'll have to find innovative African solutions to try and make sure that our cancer patients and their relatives, their families are well taken care of, and that service delivery is there in all aspects throughout the cancer continuum. Thank you, everybody. I think, Phoebe, you can close the meeting.
Thank you. Bye-bye.
Thank you very much. Bye-bye.
Thank you,
Thank
Kadas.
you.
Bye.
Bye.